Just before I introduce our speaker, you will notice that we are recording it, so hopefully that's okay with everybody. A few little housekeeping things. Please mute yourself. What we'll do is we'll take questions that are, Dr. Ditor will take questions at the end, but feel free to put things into the chat during the course of things so that we can, sort of help to moderate that and get things lined up. Other than that, thank you again. I'm going to introduce Dr. David Ditor, who's doing a presentation on targeting inflammation as a means to treat neuropathic pain and depression after spinal cord injury, a really great topic. So Dr. Ditor is a professor at the Department of Kinesiology at Brock University, and his research program focuses on secondary health conditions that accompany spinal cord injury. More specifically, his research and interests involve chronic inflammation after SCI and the associated range of negative effects that occur, and cardiovascular disease and dysfunction after SCI, and sexual dysfunction after SCI. So all super important topics. As some of these health complications are modifiable, Dr. Ditor is interested in the role of exercise and diet in managing and reversing them. He has over 75 publications in the field of SCI rehab, and his work on lowering inflammation via diet and the positive effects on depression have won open competition awards at the annual American Spinal Cord Injury Association meetings. In addition, his teaching and research responsibilities at Brock University, Dr. Ditor is also the founder and director of PowerCord, which is an accessible facility that provides specialized and supervised exercise for individuals with SCI, MS, and lower limb amputations. PowerCord is both a community-based exercise center and a research facility, and it offers a unique experiential learning opportunities to the Brock University students who implement the exercise programs, and thus we get more people with familiarity in managing these conditions. So that's excellent, and it's with great gratitude that I welcome him.
Okay, thanks very much for the introduction, and I'm very pleased to be here today to present some of the research findings from my lab and then to update you on what we're doing right now as follow-up to some of these studies. So as mentioned, I'm a professor in the Department of Kinesiology at Brock. I'm also the director and founder of a wheelchair accessible exercise facility called PowerCord. Here's our name and our logo. So traditionally, my training has been with exercise. I'm going to speak today mostly about the effects of diet and nutrition on secondary health complications after spinal cord injury. But I do want to just briefly mention what PowerCord is and what we do there as well in terms of exercise. The two topics can go hand in hand. So PowerCord is a wheelchair accessible exercise facility. We offer specialized exercise programs for people with neuromuscular disability. By and large, our membership is people with spinal cord injury and multiple sclerosis. We have a handful of other members as well. We have some people with lower limb amputations. We've got a couple people with CP or stroke, but primarily we offer exercise for people with spinal cord injury and MS. I should mention, and it's extremely important, that PowerCord is accessible in every sense of the word. So of course, the building is accessible. Of course, the equipment that we used is specialized and wheelchair accessible, and I'll show some of that. But equally importantly, the atmosphere at PowerCord is accessible. There is an extremely strong sense of belonging, and there's a real family feel at PowerCord. A lot of that is because of the relationships the members make among themselves, but a large part of that is also the relationships that the student volunteers make with the members. And people come, I think initially, obviously for the exercise at PowerCord, but they keep coming month after month and year after year, really because of this sense of belonging and the social, emotional gains they get from PowerCord as well. And we do have a wide variety of highly specialized, accessible exercise equipment. I'm just going to briefly show you some pictures if you haven't seen accessible exercise before. For example, we've got several different machines that allow for accessible resistance training. Here you can see one of our members, Christy. She's doing shoulder press on this machine, holding onto these handles here. She could have held onto these handles here and done a chest press. But the point is really, you can see here that she's doing this from her own wheelchair, which she backed into the machine. So it's wheelchair accessible resistance training. Not everyone who comes to PowerCord uses a wheelchair. We have, several people that use a walker or a cane. So you don't need to use a wheelchair. We have stools here. You can see one off to the side that people can just put in front of any piece of equipment they want, and they can use the stool instead of their wheelchair. Here's Lonnie. He's doing a preacher curl, bicep curl with this piece of equipment. And you can see, again, he's using it from his own wheelchair because Lonnie uses a wheelchair. Now, not everyone has the grip strength necessary to actually do a bicep curl, for example. So in cases where we've got people with like weak grip strength, we can just put a shoulder strap, sorry, not a shoulder strap, a wrist strap on the person. And that wrist strap would have a clip on the on one side. And in that case, we can actually hook the cable right up to the wrist strap so that even with an open hand, you can imagine the person could still perform bicep curls. Back here in the background, you can see a lat pull down machine. So we have about 6 or 7 pieces of accessible resistance training equipment. We also have quite a bit of aerobic exercise training equipment. In the background here, you can see just good old-fashioned arm ergometry. But this person that you're looking at here is using the new step machine, which allows for arms and legs in a back forth kind of motion to allow someone to get a aerobic exercise. And here you can see one of our PowerCord student volunteers side by side with a person, really helping them motivate them, get them through the exercise session, and really building that sense of rapport and that sense of belonging that we have at PowerCord. We also have a fairly new piece of equipment. This is a ski ergometer. You can see here the person is sitting in front of the machine. She's holding onto the 2 handles, and she's pulling down repetitively in a cross-country ski type motion. And so that's an excellent aerobic stimulus for this person. Again, the student volunteer is behind the person who's training. I really like this piece of equipment because it's a repetitive pulling motion instead of a repetitive pushing motion. And a lot of what people do in wheelchairs is pushing when they propel their wheelchairs on a daily basis to get around, when they're transferring, and a lot of the other exercise rehab modalities are all push. So it's nice to have a pull exercise to kind of stave off those muscle imbalances that you can otherwise get. We also have bodyweight support treadmill training. I'm not sure how familiar people are with this, but in this form of training, we can take someone with a spinal cord injury, ideally who has some amount of lower limb ability to begin with, but still would have trouble standing or certainly taking independent steps by themselves. So in this case, we can put a harness around that person's waist. That harness has shoulder straps with a clip on top. And then we can attach those shoulder straps to this kind of pulley system. We can hoist them into a standing position above the treadmill. And these pulleys here these cables are attached to a weight stack at the front of the treadmill. So we can counterbalance any given proportion of that person's body weight. And with that counterbalance, now the person can stand and maybe even take a few independent steps on the treadmill. If they still have trouble, then we can see we've got 2 student volunteers here who are holding on to the person's legs and moving their legs and assisting them through the walking motion so that they can get a sustained treadmill training session, which would help to improve walking for people with neurological disability. We also have FES, or functional electrical stimulation. And just briefly here, you can see the person sitting in front of the machine. Again, this one is wheelchair accessible, but you can see this person has sticky electrodes over top of the muscles that we're trying to stimulate. Those electrodes get connected to these cables. And in that sense, now the person is literally connected to the machine. We then send an electric current into the person's body, which causes involuntary muscle contractions. These contractions are timed in such a way that you get a very, very smooth looking either leg cycling exercise, or if you have the electrodes in the arms, you can get a very smooth looking arm cycling exercise. But it's involuntary motion, and these are involuntary muscle contractions rather than the person doing the exercise voluntarily themselves. So this is an excellent way of getting exercise, especially for people that have a total paralysis who can not activate their muscles voluntarily. And so there's no other way for them to exercise those muscles other than involuntarily stimulated contractions. So that's one piece of FES equipment. This is another one here. This piece of equipment, very similar. You can see the electrodes over top of the muscles. On this piece of equipment, however, you can stimulate all 4 limbs at the same time to get an arm-leg exercise session as well. And then last, we have circuit training at Power Court. Here you can see our jungle gym. There's various different stations that a person can use if they go around this jungle gym. Here you can see Lonnie again throwing a medicine ball and catching it off of a trampoline. Here you can see someone else using battle ropes from the wheelchair. And here you can see one of our student volunteers hitting the heavy bag, but there's 3 or 4 other stations around this piece of equipment as well. This is a really nice piece of equipment. In my opinion, it has a few really nice advantages. It really allows to train the core muscles better than any other piece of equipment I've seen. There's a lot of twisting and turning and leaning forward and leaning back and throwing and catching with this form of exercise. So it really engages the core better than any other piece of equipment I think that we have. It's very conducive to circuit training. So you can really get a combined resistance and aerobic exercise stimulus in the same session. But maybe most importantly, you can see that it's really conducive to group workouts. And not just with our members, but it's really nice once in a while when a student joins in as well. And nothing really, fosters that sense of belonging and inclusion more than a group workout, especially when it's mixed with members and student volunteers. So we really like that jungle gym we've got as well. So we know that exercise training, as I've shown, is very effective in preventing or even partially reversing many of the challenges associated with spinal cord injury. So we know that exercise can build muscle, help store glucose, and lower the risk of type 2 diabetes. It can improve cardiovascular fitness and help to stave off cardiovascular disease. And it can help with many other secondary health complications as well. But there is a growing sentiment in exercise physiology all over the world, not just for people with disability, and that is that you can't outwork a bad diet, meaning that almost no matter how hard your exercise training, it's very hard to dig yourself out of the hole you've created with exercise if you're digging that hole with a bad diet. This is especially true for people with partial paralysis, because sometimes they have trouble exercising hard enough or intense enough to really cause improvements if they're starting off with a bad diet to begin with. So we've started to study, or I've had some interest in the last several years on studying the effects of nutrition and diet on reversing some of these health complications after spinal cord injury. So what I'm going to talk to you about today is an anti-inflammatory diet that we've studied in my lab at Power Cord, with the intent of obviously lowering chronic inflammation in people with spinal cord injury and seeing what kind of positive effects we get from lowering inflammation in that way. And what I'm going to present to you today is studies that we've done that shows that this can help to lower both neuropathic pain and depression after spinal cord injury. So just a little bit of a background about inflammation after spinal cord injury. So people with spinal cord injury often live in a state of chronic inflammation. This is due for a few reasons. One, people with spinal cord injury are susceptible to infection after infection after infection, be it pressure wounds, UTIs, respiratory infections. And that can have kind of a cumulative effect on the body where the person starts to live in this state of chronic inflammation. It's not fair to say that everyone with spinal cord injury is obese, of course, but there is an increased risk of obesity after spinal cord injury, and adipose tissue itself is a source of inflammation in the body. So the higher the risk of obesity, obviously, the higher the risk of chronic inflammation. And you can say the same thing about cardiometabolic disease. Those diseases are themselves a source of chronic inflammation. And of course, there's an increased risk of things like type 2 diabetes and cardiovascular disease after spinal cord injury. So the problem is once you live with chronic inflammation, these inflammatory cells, cytokines that get released, have a negative effect on a wide array of systems in the body. Two that I'm going to talk about are that chronic inflammation can increase the risk of neuropathic pain and also can increase the risk of depression. Now, with pain, the reason why inflammation is linked to neuropathic pain is because these pro-inflammatory cytokines increase neuropathic pain by sensitizing nociceptors in the body. And when our pain receptors become more activated and more sensitive, it can lead to a much higher risk of neuropathic pain. Just to bring this to life a little bit, chronic pain is present in about, say, 70% of people with spinal cord injury, with 30% stating their pain as very severe or disabling. So it's a real problem in people that do live with chronic pain. There's various sources or types of chronic pain after spinal cord injury. One is musculoskeletal. For example, shoulder pain from always, wheelchair propulsion or transfers. This can cause overuse injuries and musculoskeletal pain. This isn't too different than the musculoskeletal pain or overuse injuries that able-bodied people would get. So it does respond to, medications like Advil or Tylenol. It gets better with rest and ice. So it's a problem, but at least it is somewhat treatable. The bigger problem after spinal cord injury, I'd say, is neuropathic pain. Neuropathic pain comes about because of hyperactivity of pain pathways in the spinal cord. So the spinal thalamic tract, which carries pain sensations from the periphery to the brain, can become hyperactive due to injury after the spinal cord, and we get spontaneous, inappropriate pain signals that can go to the brain in people with spinal cord injury. These pain signals can be completely spontaneous. The person does not have to be touched at all to experience this neuropathic pain, or it can be in response to touch, but we find that people get pain sensations from touch that would not normally be considered painful. A brush against the skin can cause pain when obviously that stimulus would not cause pain on able skin. We call that allodynia. Neuropathic pain is very difficult to treat. Standard treatment in terms of drugs are anticonvulsants. I'll get back to that later in the talk. But these medications are not 100% effective, and they do come with some pretty nasty side effects as well. And then this neuropathic pain is present in at least 50% of people with spinal cord injury. Here's just a graph I want to show. It shows various different secondary health complications on the x-axis. And they've done a nice job of separating people with spinal cord injury into those with traumatic spinal cord injury and non-traumatic spinal cord injury, as you can see in the legend there. And it shows you the percentage of people that were surveyed that showed each kind of secondary health complication. And here you can see on the far left, neuropathic pain in this study was the most common secondary health complication that affects people with traumatic and non-traumatic spinal cord injury. So again, it's very common, can be very severe, and can be very hard to treat with medication. So that's talking about neuropathic pain inflammation. What about depression? Well, here, chronic inflammation can lead to depression because cytokines can interfere with the production and usage of serotonin in the brain. And the pathway that is responsible for this or relevant to this discussion is the kynurenine pathway in the brain, which I'll go over in a minute right now. So this pathway all starts off with tryptophan, which you can see here. We would like tryptophan to be converted into serotonin in the brain. That's the precursor for serotonin, which is a neurotransmitter that makes us happy. But tryptophan can also be worked on by these enzymes here, IDO and TDO. And instead of tryptophan being converted to serotonin, tryptophan can be converted by these enzymes into kynurenine, which is part of this kynurenine pathway. So what happens when the body gets invaded by a pathogen or infection, as you can see here, is that an inflammatory response ensues, and we get a release of these pro-inflammatory cytokines in the body. And what these cytokines can do is increase the activity of these enzymes, IDO and TDO. And when you increase the activity of those enzymes, you obviously convert tryptophan more down the kynurenine path, and less is available to be converted into serotonin. Now, this is a kind of an acute response to infection or a pathogen. Oh, there we can see tryptophan being converted down to kynurenine. And this is a healthy, normal inflammatory response to a pathogen or infection. And you may wonder, why would the body do that? Why would the body actually cause tryptophan to be converted to kynurenine instead of serotonin during infection? The reason being is that these pathogens often feed on tryptophan. So this is the body's way of actually lowering the amount of tryptophan and thus kind of starving the pathogen or infection as a means to cure it. It's also actually responsible for sickness behavior. The reason why we feel antisocial and down and depressed when we're sick is because less and less tryptophan is being converted into serotonin. So this is a normal pathway that helps us to deal with infection or pathogens. The problem is when we're not talking about acute infection or pathogens, but when this is a chronic state, when we get chronic inflammation. In that case, like in spinal cord injury, with chronic inflammation, we have a chronic elevation of these cytokines. These enzymes are always overactive, and we get less and less tryptophan be converted to serotonin, more and more tryptophan being converted to kynurenine, and we can suffer from a lack of serotonin in the brain, causing depression. Now, if we treat this pharmacologically, often SSRIs are used, and those prevent the reuptake of serotonin back into the neurons that were releasing them in the brain. The problem with SSRIs is that they are not effective in, say, approximately a third of the people that use SSRIs. And even in those people that find relief initially from SSRIs, many will relapse within 6 months to a year of using that medication. So it's highly warranted to look for strategies that can help treat neuropathic pain and depression, especially those that target the root cause, which is inflammation, other than pharmacological methods. Going back to depression a bit, it's a bit difficult to generalize depression after spinal cord injury. Obviously, not everyone with a spinal cord injury is depressed, but there is certainly an increased risk. There's about a 42% overall rate of depression after spinal cord injury, with about 20% reporting major depression. And this is about a 4-fold increase compared to the able-bodied population. And then sadly as well, suicide rates are about 3 to 5 times greater among people with spinal cord injury. So I'm going to talk about a study that we did now in my lab where we looked at the effects of a 3-month anti-inflammatory diet. The whole point of this study was to see if we could use diet and nutrition to lower chronic inflammation after spinal cord injury and to see the effects that it would have on both neuropathic pain and depression. So we had 20 people in this initial study. 12 were randomized into our diet group and 8 were randomized into our control group. These people just ate as they normally would. Here you can see the breakdown of both groups. They were matched for age and gender. You can see the average age of the treatment group is about 51. The average of the control group is about 45. There is a range of complete and incomplete injuries and a range of lesion levels as well. And then time post-injury, these were all chronically injured people, about, on average 12 or 13 years post-injury. The anti-inflammatory diet itself has 2 different things to consider. The first is that we're trying to eliminate foods that are known to be pro-inflammatory. So we're eliminating foods that have a high glycemic index. So we eliminated things like refined sugars, obviously. We're trying to eliminate foods that have some kind of known intolerance. For example, many people are lactose intolerant, so we eliminated cow's milk. And even in some people that don't report a true intolerance, it could be a very mild intolerance that is asymptomatic, but is causing low-grade inflammation. So cow's milk was not allowed for anyone hydrogenated oil, so no fried foods or trans fats. And we almost completely eliminated alcohol and coffee. The participants in the diet group were allowed to have 2 bottles of beer per week, but that's all, and no other kind of wine or liquor was allowed. So we're trying to eliminate pro-inflammatory foods. We are also introducing anti-inflammatory foods or supplements. So in addition to being on a fairly regimented diet, the people in our diet group are also supplementing with omega-3, chlorella, which is an algae, a pill that had a battery of antioxidants, curcumin, and every day started off with a shake made with a vegetable-based protein powder. And we also wanted to ensure that people were actually eating what they were supposed to be eating. So we had them fill out food logs at baseline, and then after 1 month, 2 months, and 3 months of being either on this anti-inflammatory diet or in the control group. This is just a snapshot of our anti-inflammatory diet. I'm not going to go over it in great detail. I just want to point out that it's not really a calorie restrictive diet. People were given 3 meals a day plus 2 snacks a day. So breakfast, lunch, and dinner plus 2 snacks. You can see that there was no coffee. Every day started off with lemon juice and water, as well as that protein powder in a shake. And I also just want to point out, this was not a vegetarian diet. You can see that oily fish and lean poultry are offered, and even 1 night a week steak was allowed. The person who created this diet, it is a nutritionist, Joanne Smith, who works in Toronto. She has a spinal cord injury herself. Speaking with her and asking her, this probably would be even more effective if it was a vegetarian diet. But again, you want people to be able to adhere to this diet over the long term. So it's tough to get people to stick to a purely vegetarian diet. So oily fish and lean poultry was allowed more out of adherence than out of any kind of health benefit. In addition to this diet, which I just showed you, and recipes accompanied that, we also provided all our participants with this list of foods to eat and foods to avoid. There's about 5 pages to this list. I'm just showing 1 page here. But the point is, if people wanted to substitute certain ingredients on that diet I just showed you, they could. They just had to make sure they were eating foods off of the eat list and not substituting with foods from the avoid list. The foods on the eat list are all shown to be anti-inflammatory, where, as you'd expect, the foods on the avoid list are all pro-inflammatory. 99 times out of 100, this is just intuitive eating. But not all the time. There's some surprises on this list as well. You can see here that the vegetables that were on the avoid list include corn, eggplant, and pickles. I could show you similar kind of foods that may be surprising on the fruits that were to be avoided. I think, for example, blueberries were allowed, but I think it was raspberries weren't. So by and large, this is not rocket science, but there were a few surprises. So people really had to, consult this list of eat and avoid rather than just kind of going by what they thought might be healthy in a lot of instances. So in terms of what we did as outcome measures, we took blood draws at baseline, as well as after 1 month and 3 months of being in the study. We took these blood draws because we wanted to see for sure, is this actually lowering inflammation? So we tested these blood samples for pro-inflammatory cytokines, as well as anti-inflammatory cytokines. Here, IL-4, IL-10, and IL-1RA are anti-inflammatory cytokines. So we thought that our diet would probably lower pro-inflammatory cytokines, but we also wanted to see, does it actually raise anti-inflammatory cytokines, which would be a positive effect as well. We also looked at some amino acids in these blood draws to see if we did lower depression, was it because of changes that we're hypothesizing in this kynurenine pathway. We obviously measured depression. This was by self-report with the CSD questionnaire. This is a 20-item questionnaire that asks people about their feelings related to depression over the previous 7 days. The lowest score you can get is a 0. The highest score you can get is a 60. The important threshold on this scale is 15. Anyone who scores above 15 on the CSD, that score of 16 or higher is indicative of clinical depression. It's not a diagnosis, but it's indicative of clinical depression. We also measured neuropathic pain by questionnaire. We used the neuropathic pain questionnaire. There's 32 items on this questionnaire, and it breaks neuropathic pain down into sensory items, affective items, and sensitivity items as well. So it's a fairly robust questionnaire looking at neuropathic pain. Okay, so getting on to the results of this initial study, first of all, what was the compliance? Did people actually stick to the diet? The answer is yes. First of all, there was no dropouts. All 12 people that started the diet completed 3 months of the anti-inflammatory diet with an average compliance of 89%, and a range of 70% to 100% compliant, depending on the participant that we asked. One person actually did have 100% compliance to this diet over the 3 months. And I just remember, it's funny, she apologized for eating a pickle on Christmas. But this one person was very dedicated to the diet and finished with 100% compliance. So they were compliant, they stuck to the diet. Was this diet actually anti-inflammatory? And I'll show you what I want you to focus on this table, but the answer is yes. If you look at the pro-inflammatory composite, this is an average of all the pro-inflammatory cytokines that we tested. And you see here in our treatment group that from baseline to 3 months of being on the diet, there was a significant drop in the composite score of pro-inflammatory cytokines that was reduced by about 1/3 with no change in the control group. Specifically, we found decreases in the pro-inflammatory cytokines IL-2, IL-6, IL-1 beta, as well as interferon gamma. And we also had a significant decrease, at least a strong trend in PGE2. So we did get a drop in pro-inflammatory cytokines. This was an anti-inflammatory diet, truthfully. Interestingly, though, these anti-inflammatory cytokines, IL-4, IL-10, IL-1RA, they didn't change. They didn't increase. So our diet was effective in lowering pro-inflammatory cytokines, but it did not have the effect of increasing anti-inflammatory cytokines. So what were the effects on depression and pain? First, we'll look at depression. And here, actually, we see a really nice effect. There was a significant group by time interaction for depression. And here we see that there was a drop. Here's our treatment group on the left. They had a decrease in their CSD scores from about 14.5 on average down to about 6.5. Well, they made a large change even after 1 month, and it was maintained after 3 months. And we had no change in our control group. So we had a really nice drop in depression scores by about 55%. And quite quickly, even after 1 month of being on this diet, we saw a large decrease in depression scores in our diet group. I want to remind everyone that on the CSD scale, anything above a 15 is indicative of clinical depression. At baseline, our 12 participants were really hovering around that level. And then even 1 month after injury, there was a real drop in that. Of our 12 participants, 5 of them started off with scores well above 16. And all 5 of those people dropped to scores below 15, even within 1 month of being on the diet. Further analysis showed that the change in IL-1 beta specifically, that cytokine, seemed to be responsible for the changes in our CSD scores, in our depression scores. So just graphically, it would seem that our anti-inflammatory diet lowered inflammation, but specifically lowering IL-1 beta seemed to likely decrease the activity of IDO and TDO, meaning less and less tryptophan was being converted into kynurenine and more tryptophan was being converted into serotonin. That was accounting for our effects on depression. In terms of what we found for neuropathic pain, again, here we found a significant group by time interaction, but only for the sensory subscale of neuropathic pain. We found no effect on affective or sensitivity, but we did get about a 40% reduction in the sensory scores for neuropathic pain in our treatment group, with no change in our control group. So again, we found quite a large interaction here with a sizable drop in neuropathic pain in our diet group only. One thing I want to point out here, we did not have, I'd say, equal amounts of neuropathic pain in our two groups at baseline, unfortunately. So we didn't pre-screen or match the groups for neuropathic pain in this study, but I'll come back to that because we are actually addressing that limitation in studies that are ongoing right now. But yes, just to emphasize, we also found this group by time interaction for neuropathic pain with our diet. Again, further analysis showed that changes in sensory pain seem to correspond to decreases that we found in interferon gamma and PG2. And the changes in these inflammatory mediators accounted for about 40% of the change that we saw in sensory pain scores. So lowering these two cytokines in particular seem to be responsible for lowering our neuropathic pain. So how does this compare to standard treatment? We know our diet seemed to be effective, but how does it actually work into the literature? Is it as effective, less effective, more effective than what people are actually using to treat neuropathic pain and depression right now? For neuropathic pain, like I said, the anticonvulsants pregabalin and gabapentin are standard treatment. Here we see a very large randomized control trial, 137 people with spinal cord injury that used either pregabalin or placebo. And pregabalin reduced neuropathic pain scores by about 29% in that RCT. Here's another RCT that looked at gabapentin, and this drug lowered neuropathic pain by about 62%. Now, we dropped neuropathic pain by about 40% with our diet. So we're in the conversation in terms of having a magnitude of effect that's actually currently being seen for some of the drug treatments right now that people are using. But with pregabalin and gabapentin, there are some nasty side effects, one being constipation, which is already a problem after spinal cord injury, and one being troubling psychologic side effects as well. Obviously, you don't get these side effects with our anti-inflammatory diet, so it seems to be seemingly as effective as the drugs that are being used now without the side effects. What about depression? Well, in addition to SSRIs, which I already talked about, cognitive behavior therapy is quite common to treat depression after spinal cord injury. Here's one study that looked at newly injured individuals who were admitted to an SCI ward in the hospital. 28 received cognitive behavior therapy, 41 received only traditional rehab. They measured depression with the Beck Depression Inventory, which is different than the scale we used. It goes from 0 to 63, and anything 14 or higher indicates clinical depression. And they also measure depression at pre, post, and 1-year follow-up. In that study, both groups, the CBT group and the rehab group, both saw decreases in depression, but no interaction between the two groups. So both treatments seem to be effective in reducing depression, but that's when all participants were considered together. They did a sub-analysis on this, and they looked at only those people that were actually clinically depressed. So anyone who scored a 14 or higher in this study was used in a subgroup analysis. And in that analysis, they're showing you that actually, yes, CBT, shown in the bars just to the left here, seemed to be more effective than standard treatment. And in those people that show depression, with CBT, they had about a 60% reduction in depression. Now, we had about a 55% reduction with our diet. So again, in the conversation with other strategies that are being used to treat depression after spinal cord injury. So just in conclusion, chronic inflammation does contribute to neuropathic pain and depression after spinal cord injury, and reducing inflammation, which we did with our anti-inflammatory diet, seemed to be effective in reducing pain and depression in our participants. Now, that was very encouraging and very nice, but we also want to see were people actually sticking to this diet long term. So we looked at the effects of our diet at a 1-year follow-up. So we had 7 people that were from our initial diet group. 1 year after the study was over, we again collected their food logs over 3 days and retested them for pain and depression. I just want to remind you that in our study, we had an 89% compliance rate to the diet. 1 year later, you may be surprised or maybe not be surprised to find out that adherence dropped all the way down to 43%. So despite all these nice changes that we actually found, 1 year later, people were eating basically just like they were at baseline with their usual diet they'd been living with before the study. And as you'd expect, we also found rebounds in especially depression and somewhat in neuropathic pain as well. So we did yet another study to try to identify why was this? Why is it that despite all these benefits, 1 year later, people weren't eating, adhering to this anti-inflammatory diet? So we did a qualitative study trying to find some of the barriers and facilitators to adhering to this anti-inflammatory diet. We had 6 people in that study from our diet group. They either did a one-on-one interview or participated in a focus group or participated in both. And just some facilitators here, what made it easy for people to stick to this diet? If they had family support, that was very, very helpful. If they had control over their own meal choices, if they were the person responsible for grocery shopping and meal preparation for themselves, that was a facilitator. People that were dependent on others didn't always have an easy time sticking to the diet if that person obviously wasn't helping them buy the right foods and prepare the right meals. Peer support from fellow dieters. Again, these 12 people were chatting with each other during a study, so they found some peer support, helped them to adhere to the diet. And then the health benefits. Not only were they finding reductions in pain and depression, a lot of them lost quite a bit of weight on the diet. A lot of them reported improved cognitive function, and a lot reported bowel function as well. And so that made it easier or more encouraging to stick to the diet when they were on it. And then last was implementing adherence strategies. This is just kind of a fancy way of saying that we built in cheating into this diet. We didn't build in cheating this diet, but those people that had a strategy for cheating once in a while found it easier to stick to the diet. Some people would cheat maybe 1 meal a week, but sometimes that can help overall adherence, to know that you can cheat once in a while, and this isn't like a life sentence that you can never have a cookie ever again. If you allow yourself to cheat once in a while, it can help overall adherence. Some barriers to sticking to this diet, 1 year later, they didn't feel obligated. They weren't no longer in a study. Social events are always hard to adhere to a diet when you're at a social event, Christmas, Thanksgiving, whatever it is. We supplied them with their supplements when they were in the study, but these are quite expensive, and they were on their own to buy the supplements after the study was over. So expense, especially of the supplements, can be a problem. And then just lack of knowledge regarding meal planning and preparation. Over the long haul, people can find this a barrier to sticking to the diet long-term as well. I just want to briefly talk about some limitations and some future directions, and then I'll wrap it up and open up to questions here. So our studies were very encouraging, but we have to be realistic. It's a relatively small sample size, 20 people in those studies and 12 in the diet group. And like I said, our participants were not pre-screened or matched for neuropathic pain. We are now doing a study called the catnip study. It's funded by the Ontario Neurotrauma Foundation. It's a 3-year study that I'm doing in collaboration with Dr. Eldon Lowe in London, Ontario. In the catnip study, we were again looking at the effects of an anti-inflammatory diet or cannabis alone or in combination And we're looking at these strategies specifically on their effects of neuropathic pain after spinal cord injury. So this study is going to address our previous problem with a low sample. We'll have 140 males and females with spinal cord injury, and everyone is going to be pre-screened for existing problematic neuropathic pain. So it'll address that limitation to our previous studies as well. These are showing kind of the 4 groups that we'll have in that study, but again, they'll be either on an anti-inflammatory diet or taking cannabis alone or in combination. Another limitation to our previous work was that this is difficult to adhere to over the long term. Compliance really dropped 1 year after our study was done, and this diet has not yet been translated into actual practice. So in PowerCord now, I'm trying to implement what I call the Mad Dog nutrition program, where we would actually help people adhere to this anti-inflammatory diet long term. One way we're doing this is we've retooled the diet a little bit. Instead of being a 7-day-a-week diet, it's a 5-day-a-week diet. So 2 days a week, people are allowed to we're not hoping they cheat every meal for those 2 days, but they're allowed, they have a bit more freedom 2 days a week. We're not using supplements, so it keeps down the expense. And we've redesigned the diet so that it is a little bit more palatable and a bit easier to prepare. And we're currently testing this diet for effectiveness in PowerCord. And we've got some nice preliminary results. We also have developed a consult, a one-time consult that people can sign up for before taking on a diet like this. It's a 2-part consult. One part involves a home visit where we show people how to prepare selected meals from the Mad Dog diet. And the second part is an accompanied trip to the person's grocery store to show them how to kind of shop for value and shop wisely to help adhere to an anti-inflammatory diet. So that's all I have to say again today. That's what's kind of going on in my lab now and the changes we're trying to implement at PowerCord. And I thank you very much for listening, and I'm more than happy to take some questions.
Well, that's great, Dr. Dieter. Thanks so much for that excellent presentation. I'll get into a couple. We do have a few questions in the chat. So Gwen Dziwenko had said that she was wondering if there was any monitoring of changes to medications during the study. So I guess whether or recommendations of changes or whether new medications were added or changed. Can you comment on that?
Yeah, we encourage people to stay on the same medications throughout the 3 months. And we did monitor it, but we didn't enforce anything, obviously, because ethically we can't do that. We found that by and large, most people were stable with their medication. We did have a few people no one increased their medication. A few people were able to lower their pain medication. So it's actually quite encouraging that we had these positive effects on neuropathic pain, even though, people are either stable on their meds or even actually lowering their meds. So that's a tough thing to control for in any clinical study because you can't enforce people to do certain things with medication, but it certainly didn't confound any of our findings. Yeah.
Great. John Chernesky has asked if there was any support for food and meal prep for those with tetraplegia. I know you talked a bit about some financial support for the supplements and that type of thing, but I think John's referring a bit more to physical supports as well.
Yeah. Okay. So that was not addressed during our initial studies, but that is actually part of our Mad Dog consult. So when we go into the person's home, we're going there to show them how to make some selected meals from the Mad Dog diet, but we are also bringing and demonstrating several pieces of accessible cooking equipment. So the people with either low grip function, for example, who can't necessarily hold a knife or have trouble with heavy, pots and pans and cooking equipment, we're bringing some accessible cooking equipment into their home, and we're demonstrating it for them as well. So if they choose to buy some of this equipment, we show them where they can purchase it. And we're hoping that that helps people with their meal preparation and helping to break some of those barriers over the long term for some people as well, because that certainly is a problem. Meal prep was identified as one of our barriers. and that research is published as well. If you want to look at, what those barriers are in more detail, I went over them quite quickly. But we think that, at least nudging people in the direction to some strategic, accessible cooking equipment will also help to reduce that barrier for people that have some disability and have trouble with preparing food.
Thank you. And John, if you had anything else around there, just go ahead and chime in. Melanie Cullum is asking if you can get a copy of this anti-inflammatory diet. Is that available anywhere?
Yeah, if anyone wants to email me, I can send you the diet. I do want to mention the diet was created by Joanne Smith, who's a nutritionist. She has a spinal cord injury herself. And she's the founder of Fruitful Elements. It's her nutrition business, and she has various diets for people with a range of disease or disability. So her anti-inflammatory diet was developed by her. That's the one that we used, but it is also ever evolving. The diet that we used in that study years ago has been modified a few times, so that certain foods that you would have found on the either eat or avoid list back then have been modified, so they may or may not be allowed now. A good example of that is that back when we started these studies, we weren't really aware of the effect of lectins, for example, and their pro-inflammatory effects or their effects on the gut. Now we're know more about lectins, and they be restricted from any diet that we'd be studying. So for example, now, if you want to eat beans, they have to be pressure cooked, for example, which is one way of getting lectins out of beans. The skin of cucumbers have lectins. So the diet is ever evolving. As more and more research comes out, we're able to kind of improve this diet over and over again. So yeah, if anyone's interested, I can send that diet. But again, take it with a grain of salt, I guess, because it's a fluid, ever evolving kind of diet.
Craig, do you want to come on and just ask your question if you're able to there?
Yeah, sure. I was just wondering, you hear a lot about anti-inflammatory diets, and you hear about like the Mediterranean diet, and then you also hear naturopaths talk about an anti-inflammatory diet. Is yours kind of like a hybrid, kind of somewhere in between, or how would you describe it?
Yeah, that's a great question. There's a whole bunch of diets out there that have shown some kind of benefit. So there's the Mediterranean diet, there's the ketogenic diet, there's the Walls protocol diet that's more geared towards MS. There's several different diets that have been studied and all showed have some kind of anti-inflammatory benefit. And they have some similarities, they have some differences, and it's not really known which is the best, or is there a best? If you ask me, I think you got to keep in mind what is common about all these diets. The ketogenic diet is quite different. It's very different than our anti-inflammatory diet, but they both reduce inflammation. And one thing all these diets have in common isn't so much what are you eating. They all obviously recommend healthy foods, but the one thing in common is they all are eliminating all of these processed foods, all these trans fats and processed foods. And I think really, if you have to do one thing, is not nitpick which diet is the best in terms of what is allowed to be eaten, but really they all have one thing in common, is they all eliminate the crap. And that may be the most important thing about any of these strategies, is to really get rid of the processed foods, get rid of the deep fried foods, so on and so forth. So we don't really know which of these diets is the best, but if you ask me, I think that's one very important component of them all.
Yeah, that's practical advice. John, do you want to ask your question? We'll take a couple more, maybe John and Vanessa.
Sure. Thanks, Jamie. Hi, David. A great presentation, by the way.
Thank you.
It's fascinating to see people working in this area. Really, my questions are around the practicality and the applicability of this, right? So that's what I was asking about food prep and the challenges that might be there, but also thinking about, a lot of folks with spinal cord injury are living on fixed incomes.
Yeah.
So were there any significant differences in the cost of the low inflammatory diet compared to the participants' baseline diets? Like, is it practical for somebody to put this change into their lifestyle?
Yeah, the most expensive part that's difficult to adhere to is the supplements. If you just looked at stacked up ingredients of what they're normally eating, like food ingredients from what they're normally eating compared to being on our anti-inflammatory diet, they were comparable. I wouldn't say they're exactly the same. It depends what the person's eating baseline, and it depends how about they're going to buy their anti-inflammatory ingredients. You can do that expensively or fairly cheaply as well. They were comparable. I'd say they're a bit more expensive for the ingredients of the anti-inflammatory diet. You can do better by shopping at the bulk barn. You can do better by shopping at farmers markets. But yeah, healthy produce in a grocery store is a bit more expensive than what they're eating baseline. But they're comparable. The real expense was the supplements. And that's the part that people would really have trouble, I think, affording, especially with fixed incomes. Now, the Mad Dog diet, which we just developed, we eliminated all the supplements and we tried, and we analyzed the diet. So we tried to pack all of that missing nutrition from the supplements. We tried to pack it into the diet with food. And we analyzed our initial diet, anti-inflammatory diet, with our new Mad Dog diet, and they were actually matched for macros and micronutrients. So you can do it. I mean, you can get that nutrition from food alone, but it's an extra challenge. We also found in that Mad Dog diet, we have preliminary results. I have to say, COVID didn't help that study at all. It didn't turn out to what we wanted it to be, actually, in terms of the numbers of participants. We had a trend for lowering inflammation with that study, but it wasn't as dramatic as what we found with our initial study. Now, that could be because we didn't have supplements. It also could be because it was a 5-day diet instead of a 7-day diet. I think it was both. I think that if you can't afford supplements, which is understandable, you can partially make up for that with food, but you really may not get the full benefit. So yes, it is a barrier that's hard to overcome.
Vanessa?
Oh, thanks, Jamie. And thank you, Dave, for the wonderful presentation. It's wonderful to see work going on in the area of diet and nutrition. I just had a question, and I joined late, and you might have mentioned it, but as you were running these studies during COVID and you were looking at cytokine responses and inflammatory response, how did you manage for COVID going on at the same time as this? And was that captured? And how did you look at the interaction, I guess, between other infectious diseases going on at the same time?
Yeah, the study I spent most of my time talking about today, that initial study with 20 participants, that was way back before COVID. That was a study we did in 2014-15. So there was no confounding effects of COVID on that study. When we modified our anti-inflammatory diet to this new Mad Dog diet, we intended on looking, and again, that's the 5-day-a-week. It was designed by local chefs in our community. It's designed to be tastier and easier to adhere to, and cheaper. But COVID really played havoc on that study. We really want to do, again, a nice big randomized control trial looking at the Mad Dog diet versus control participants. In the end, we only ended up with 6 participants in that study and no control group. So COVID did have a big effect on that study. But, again, we still did have a trend for a drop in inflammation. And in this study, we actually specifically looked at body composition, and we did find, again, what we found anecdotally in our initial study, but this time we actually measured it. We did DEXA scans on those 6 people, and we did find that they did have significant losses in fat mass. Unfortunately, they also had losses in lean mass. And so, again, this was really affected by COVID. We didn't test as many people as we wanted to. But it looks like with this diet, it has a lot of benefit. One of those is going to be fat loss, but I think you really have to pair any of these diets with resistance training so that you can lose the fat, but maintain the muscle mass at the same time. But during COVID, those 6 people, it made it difficult to do the study, but none of them actually had COVID while they were in the study.
Okay, thanks.
Yeah.
Well, thanks once again, Dr. Dieter, for just a great presentation and for joining us. Thanks for everybody for attending today. His email is in the chat if you want to jot that down to get a copy of the diet or ask any questions. We'll be taking a break from the webinars over the summer, but we'll be returning in September. We'll have 2 webinars, one scheduled for pressure ulcers and another one for cardiometabolic monitoring and SEI. So hopefully everybody will join us then. Just keep an eye open for the emails, and everybody have a great summer, and thanks again.
Thanks very much. It's a pleasure to be here today.